Okay.
And here's the question. Just 10 seconds left. Yes. So if you have read and understood, kindly begin your history taking.
Okay. I will enter the room. I will introduce myself. Hello, my name is Dr. Ishfaq. I'm one of the doctors working here. May I confirm your name and age, please?
Hello, I'm John. I'm 42 years old.
Nice to meet you, John. Today I have been asked to ask you a few questions regarding your condition. Will that be okay for you?
Yes, sure, doctor.
Okay, great, John. So we can proceed. So can you please tell me how can I help you today?
Okay, so actually I'm having severe low back pain for quite some time, but
Okay.
since last 24 hours, it's so severe that I'm unable to do anything, even walk. So I've come to you for help. If you could please alleviate the pain in any way possible, doctor.
Okay, John. I'm really sorry to hear that out there. Have been suffering from pain from last 24 hours. Do you mind if you tell me more about your condition? When did the pain exactly started and where exactly is the pain?
Oh, I've been having this pain for quite long time, like approximately 4 years or so. But I've been trying to live my life with that pain. But in the last 24
Okay.
hours, I saw sudden change and sudden severity in the increase in the pain, and now it's so severe that I can feel it on both my buttocks, and
Okay.
also I'm having some problems, like it is very getting very difficult to pass urine for the, and I'm having some problem with my bowel movement too. So yeah, that's
Okay.
actually what's been happening.
I'm really sorry to hear that out. Can you please tell me, you told me it started 4 years ago and now it is, severe from last 24 hours. Do you think the pain is going down your, towards your legs, towards your feet? You told me it
Yes,
has been
yes,
here to
it
what
does.
here? Okay.
Not to my
Anywhere
feet,
else?
not up to my feet, just up to
Okay.
my calf and the buttocks,
Okay.
and
Okay.
that's it.
Okay. So do you think the pain is, hampering your daily activities?
Yes, it is. It is. It's like I told you previously. I was trying to tolerate it, but it's got intolerable in the last 24 hours.
Okay. Have been able to walk, or do you have to, take small pauses while walking? Any difficulties with walking?
I do take small pauses while walking, but I'm able
Hmm.
to climb stairs and everything. That is, yeah.
Okay. Can you please describe the character of pain for me? Like it's sharp pain, it's cutting pain, it's burning pain, it's dull pain. What do you think the pain is?
It's like a burning sensation back there in my
Okay.
lower back.
Uh,
Yeah.
okay. Okay, so if you have to rate the pain, from 0 to 10 being the worst imaginable pain you have ever felt, one being the lowest, on the lowest, towards the lowest side, how will you rate it?
7.
Oh my, okay, okay. I'm really sorry to hear that out. Okay,
It's all
do you
right,
think?
doctor.
Okay, do you think you have any stiffness in your joints, like your back, like your other joints, your knees, your elbows, any other joints? Morning stiffness, night stiffness.
No, no,
Okay,
not
no.
really, doctor.
Okay, how has been your appetite?
It's okay. It's fine.
Okay, how? Okay, nice, great. So how has been your, have you lost any weight recently, unintentional that too?
No, not really. Not that I
Okay,
noticed.
okay, great. Have you been experiencing any fevers recently?
No, doctor.
Okay, so you told me you have the issues with the, bowels and waters recently.
Mm-hmm.
Do you mind if you ask some few personal question? You might
Not
be
at all, doctor.
feeling
Go
you
ahead.
don't. Okay, okay, you don't have to feel embarrassed. Do you think you have been feeling abnormal sensations right in your in genital areas or your lower legs or feet, something like that?
Yes, yes, I have noticed something like that, actually, doctor.
Okay, any weakness in the legs or buttock area or any other
Mm,
part of the body?
no, it's just sometimes tingling sensation, doctor.
Okay, right, right. So, have been experiencing any other pain, the joints, any muscle pain, any shortness of breath, any chest pain, something like that?
Mm, no, not that I
Okay,
noticed.
okay, okay, great. So, is there anyone else in your family who has been experiencing the same in the past or experienced the same?
No, doctor, not that I know of.
Okay, is there any other condition you see your GP for?
No, I'm actually well. Other than this low back pain, I've got no
Hmm.
other problem.
Okay, are you taking any medications?
Just sometimes simple analgesia for this pain.
Okay, have you any allergies, to any food or any drug?
Not that I know of, doctor.
Okay. Do you mind if you ask if I ask some personal questions?
No, go ahead, doctor.
Okay. Can you please tell me what do you do for a living?
I work in a firm.
Okay, that's great. So, who is at home with you?
My wife and my 2 year old, my two children.
Okay, that's great. So, before proceeding further, can you please tell me what do you think? What might be causing your problem?
I don't know, doctor, because you see, I did not even,
Mm-hmm.
I have not had a fall or anything. All of a sudden, I've been having this pain. So, yeah, I can't really think of
Okay.
any reason.
Okay. Right. I understand. I understand. So, what's your most important concern regarding your condition?
Just this thing, and also my bowel problems and my
Right.
urinary problems that I'm having.
Right. I understand that. So, what are you hoping us to do for you today?
Uh, Anything that could just decrease this pain.
Okay. So, have you had any fall or any trauma or any other any other type of injury recently? You would like to tell me?
I can't really recall.
Okay. Thank you very much, John. Thank you very much for your time.
Thank you,
That
doctor.
Yes.
I appreciate your
Can you
time.
please
Okay.
present
Today
your
I would
case?
like to
Yes.
present my case. Okay. Okay. Today I have taken history from a 42-year-old male, John, who complained with lower back pain from last 4 years. He had a sudden change in the nature of the pain from last 24 hours. It's going down into her buttocks and as well as the thighs and calf muscles. Patient
Yes.
is he's also experienced a difficulty passing urine with a hesitancy, but he had not history of any. He had not any episode of incontinence. Patient is not able to open his bowels today.
Okay.
So there is no significant past medical history or surgical history. There is no drug allergy or no other recreational drug use. Patient is worried about that it might be some serious issue. So
So, what is your
he's
differential
hoping to
diagnosis?
do something as soon as possible.
Yes.
So my top differential diagnosis would be the CAUDA syndrome,
Yes.
but I would also like to rule out other causes like prolapse in intervertebral disc, any infective pathology, any ankylosing spondylitis, any arthritis, osteoarthritis, or rheumatoid arthritis as well.
Okay. So, how would you manage this patient? What investigations would you ask for?
After a thorough history and clinical examination, I would like to do some blood investigations like routine blood count, full blood count, urea electrolytes, LFTs, markers of inflammation, ESR, CSR, sorry, CRP, ESR, and rheumatoid factor as well. And I also like to do the X-ray, lumbar spine, EP, and lateral view in this patient. After that, I would like to do urgently an MRI in this patient, as I'm suspecting that she is having cardiac syndrome, to rule out where the compression is. After that, I would like to discuss the case with my consultant, and we need to get in touch with a neurosurgeon as well. And soon we have to arrange the theater for this patient as soon as possible to decompress the spinal cord and to relieve his symptoms.
Okay, good. Yes, thank you. Good.
Thank you very much, ma'am. Thank you, Dr.
Yes,
Ulfat.
this has been discussed before, but would you
Thank you.
mind discussing it? Would you?
Yes, yes, ma'am. This is a sagittal view of the MRI at the level of the thoracolumbar region.
Yes,
It is showing spinal cord compression at the level of L4, L5, and L4 mostly. And this is usually it can be a case
yeah,
of prolapse intervertebral disc, or patient can be having also caudal syndrome as well. Depends
yes,
upon
good.
this thing.
Okay, thank you. What are they saying? Yes. Little
Thank
time
you very
you
much.
took extra, yeah, because it's
Yes,
elongated. Yes, L5, S1, yes. Good. It's just that
thank you.
little time you took extra, but as soon as bell went, you started to wind it off, and that extra 30 second, that, yeah, but we are working on it, so hopefully,
Yes, ma'am. Hopefully.
yes, we'll soon get there
Thank you.
where our aim
Yes,
is.
ma'am.
Yes, anyone else want to give feedback? Yes,
Hello, ma'am. How are you?
yes, here is the question. Right. If you have read and understood, kindly tell me. Considering it critical care scenario, what is your provisional diagnosis?
Ma'am, as per the history that has given about this patient, he has been just in the post-op recovery. It's more likely to be the fluid overload. And
Yes,
as per the resetting has been seen in the scenario, so it could be also leading to the pulmonary edema.
very good. So, how would you go and how would you go about managing this patient?
Are we managing this patient according to ABC or either the CRISP protocol? The first of all, I'll make sure the patient have an intact airway, and then breathing, I'll make sure the patient have patient have an oxygen mask having enough oxygenation. Along with that, I'll make sure if the patient having an issue in any kind of breathing, that has to be addressed first. In circulation, I make sure if the patient is having any excessive fluid, that has to be halted at that spot,
Very good.
and patient should be giving the agents with the decrease in the pressure, such as furosemide, nitroprusside, aminophylline, these agents. And along with that, I'll make sure I'll go through the patient, the previous histories and previous chart of his procedures and all the input output charting. And in these scenarios, or also make sure that the patient had the chest X-rays, ECG, ABGs, and UCs as well.
What are the findings that you expect to see on chest X-ray?
Okay, ma'am. This is a basically a posterior chest X-ray of a gentleman, more likely showing the bed sign, which are the basically sign about the pulmonary edema, which is due to alveolar edema. And the second sign I can see in this X-ray is a Gallbladder sign, which basically showed a transfer linear lines on the periphery, going from the pleura to the lung parenchyma. The next thing would be the cardiomegaly, and the fourth thing would be the dilatation of the hilar vessel from hilum to the upper lobe.
Okay, patient has been resuscitated with 7 liter of fluid,
Yes,
but
ma'am.
why is patient oligouric, please?
Ma'am, this is basically multifactorial. First of all, the patient has been in a post-operative period. That will lead to the activation and recruitment of the physiological stress and activation of mineralocorticoid, glucocorticoid. That will lead to the retention of salt in water. The second thing would be the anesthetic agents as well as a surgical trauma. That will lead to the activation of ADH vasopressin. That will lead to the activation retention of the solute-free water. And third, and that would be very most important, is that the decreased yield perfusion that will lead to the oliguria as well. So they all confound each other and will lead to the oliguria in such patients.
What is the minimum amount of urinary output that one can have?
0.5 ml per kg per hour.
Okay. Can you please tell me how should this patient have been resuscitated?
Ma'am, this patient, first of all, there should be a CVP line and monitoring, urine output monitoring, adequate input-output charting should have been done in such patient, and very judiciously saline should have been given to this patient without overhydrating.
Okay. Can you tell me what are the findings that lead you to think that it is fluid overload? What would you look for in the patient? Yes.
Ma'am, basically the patient hypertensive, oliguric, hypertensive, tachycardic, descending, oliguric, and despite he has been given the furosemide, he is not responding. And second thing that he has been given almost 7 liters of the fluid, in which the 4 liters are normal saline.
But what would you find on examination that would point you towards that it's fluid overload?
Ma'am, first of all, the patient would be confused. Second, the patient might have a puffy face, and along with that would be CBP would be erased, and it's a brick capitation in the chest.
Yes. Yes. Congested neck veins as well. Okay.
Yes, ma'am.
Can you tell me why this patient might have high risk of myocardial infarction?
Would lead to the decrease in diastolic time, which is a very much important time for the coronary refilling. That would lead to an increase in the cardiac load and will predispose patient for the myocardial ischemia.
Okay, very good. Where do you think this patient should be managed?
Ma'am, HDU.
Okay, who would you involve in the management of this patient?
Ma'am, I'll be managing, involving the internal medicine doctor along with that the Swiss medicine specialist and the physiotherapist.
What measures or precautions can be taken to prevent this happening in the future to the same
And
patient?
first of all, yes, the first of all those patients who has been in the procedure should have adequate input-output charting. Along with that, should be adequate monitoring of the CPP. Along with that, there should be an adequate monitoring of the urinary output, and a very good education of all the junior doctors or the nursing staff who's carrying out the care of such patients. And the incident report should be generated, and thorough investigation should be done in such patients that what has led to this.
Okay, can you tell me how blood pressure should be calculated?
Ma'am, basically blood pressure is a component of two things, which is a cardiac output and total peripheral resistance.
Okay, so what are the options that you will follow to monitor fluid balance status?
Ma'am, there should be input-output charting and blood pressure, vitals, and pulse, and CVP monitoring.
Yes. Okay, can you tell me the composition of normal saline?
Ma'am, normal saline basically constitute of 144 MEQs of sodium and 154 MEQs of the chloride.
Okay, so what is the average sodium requirement for a patient, for a person
Ma'am, for a normal
daily?
patient, it would be required around 1 to 2 MEQs per kg per day.
Okay, what about potassium? How much is it
Ma'am,
needed?
0.5 to 1 MEQ per kg per day.
If patient goes into cardiac failure, what medications or what management would you recommend?
Ma'am, first was starting with the least invasive, like starting the propping up the patient, and
Yes.
make sure if the patient already been overhydrated, decrease the fluid all, and start giving the diuretic in order to reduce the overload. And meanwhile, if the pressures are on the higher side, you will give certain medications, decrease the preload and afterload. And if the patient been on the lower side of the pressure, you might have to start the inotropic support.
Okay. If you're monitoring your patients every 2 hours, do you think that monitoring is adequate? Good
Ma'am,
enough?
I think ideally the patient should be managed on the cardiac monitor, and he should be checked like after each hourly. In
Yes.
HD would be yes.
If you're yes, if you're monitoring and patient is not responding to your management, who would you contact first? Who would you notify
Um,
about the progress of your patient?
Ma'am, I think the surgeon and the medicine team.
Yeah, or your consultant. Okay.
Yes.
Patient requires increased maintenance fluid. How would you go about taking precautions or considering all this in your mind? What are the
Ma'am, I
complications
think,
that you look out for or to avoid?
ma'am, sorry, could you please repeat?
Yes, conditions like require increased maintenance fluid. So what are the complications or conditions that you'll keep in your mind while giving the maintenance fluid? What are the
Ma'am, I'll make sure
yes?
I'll make sure the patient does not undergo the overload again. It should be giving very judiciously. Should not be overhydrating the patient.
Since it's a post-op patient, so you'll keep in your mind there is no pyrexia, there is no ileus, this patient is not vomiting, there is no other
Okay.
complications like pancreatitis, etc. is happening, there's no fistula formation, etc. So these are the small things that you'll keep in your mind
Okay,
while
ma'am.
giving the
Okay, okay,
maintenance
okay.
fluid. Okay, very good, very good. Thank you.
Thank
Yes, anyone else want to give feedback?
Signers, Dr. Tashova, I guess.
Okay.
Detailed one. The patient fulfills all the criteria for the admission in ITU. That's why this patient will be basically in intensive care rather than in high dependency ward, I feel.
Oh, okay. What
Because
is the difference? Why
because
intensive care and why not high dependency unit? It's post-op patient.
the criteria for ITU says that
Yes.
two organs that is involved, one of them that is chronically affected and the second one going into failure. So in this case, the patient, we've got the cardiac system, the respiratory system, and the renal system, all
Yes.
three of them affected.
And what is the criteria for high dependency
Criteria
unit?
that they fill up, that then the patient gets admitted in ITU. Yes, ma'am, that's why. And
Yes.
also like how
Yes.
Dr. Abhishek has said, 1:1 nursing, and 1:1 nursing care this patient will be requiring. So yeah,
Yes.
basically the patient fills up all the three criteria for ITU admission, ma'am.
ITU.
That's
But
why.
what is the criteria for HTU? High dependency unit.
There is
Yes,
one, but
Dr. Abhishek. Yes, please.
I can't recall it right
Yeah,
now. But
ma'am.
there is
We'll
Actually,
learn.
the
there is
Yes.
a
criteria
criteria.
for HDU is, ma'am, at least one organ is damaged, and that is not definitely the respiratory system. And if the patient need any detailed observation for any critical condition rather than the respiratory system, and also in case such case of like post-operative observation, like overnight observation in the HDU. And another one is patient needs at least 3:1 nursing criteria, and definitely the reversible organ damage. This
Is
is the
there any
criteria of
damage?
HDU, ma'am.
Is there any damage which has happened more than one organ system or more than one system has already happened here?
In this case, ma'am,
Yes, in this scenario.
yeah, ma'am. In this case, actually, ma'am, the respiratory system is mainly affected, like the fluid
Yes,
overload and the
yes,
pulmonary edema
yes,
patient is having desaturation. And secondly, a patient is having also cardiac compromise, and also the renal system is altered. The patient is having oliguria. So I
yes,
think both are the
oliguria,
reversible causes,
tachycardia.
and also the patient may need the respiratory supports. So right now,
Uh,
I cannot tell, like patient is having
right,
desaturation.
yes.
Yeah,
Patient is tachycardic as well, hypertensive as well. Okay, yes,
yeah, ma'am.
all right, yeah. But then, even then, it's written like a high dependency unit. So HTU, yeah. If you can justify your answer in exam, then go ahead. Otherwise, yeah, things are happening but haven't happened yet. So they are on the way. Yes. Okay. Like failure of
Yes, ma'am.
cardiac system and renal system, like they are on the way but hasn't happened yet. So all right, good, thank you. Started the timer and Yes, here is the question. Right. If you have read and understood, kindly begin your examination.
Okay. First of all, after entering the room, I'll wash both my hands and introduce myself to the examiner and the patient, and I confirm the name and age of the patient. Then I'll try to take the permission from the patient if she can to do the examination of the cranial nerves. So with a start, I'll ask if she can hear anything or she has any pain in her ear or anywhere else and she needs anything. Although she is semi-comatose, but she can respond little. So I'll start to doing looking at her ear and surrounding area if there is any signs of basal skull fracture, and then I'll ask the patient that to see if I will ask that I'm going to do the test, which will be the whisper test. I'll cover the right ear of the patient, and then also I rub the tragus of the right ear, and I will whisper a word behind his ear, about 15 centimeter from the left ear. Then I'll try to ask the patient to repeat the word. If patient can repeat the word, then it's okay. I'll again change the distance more, and I'll see if the patient, normally the patient can perceive it up to the 60 centimeter. I'll test that same on the opposite ear also. Then I'll do the using the tuning fork. I'll do the Rene's test. I'll tap this tuning fork, which is 512 hertz, and keep it at the uh, front near the external auditory meatus, and I explain the patient that if she can hear it, then she will say that she can hear it, then I'll put it the fork over her mastoid process, and then I'll ask if she can hear it again. If she is hearing, and then when she'll say that it is now I cannot hear, then I'll bring it back in front of the ear. If she cannot hear it, I'll do the same on the opposite ear also. So it will test whether the air conduction is more than the bone conduction, or it is bone conduction is better than air conduction. Then I will do the Weber's test by tapping it and placing it over the forehead in the midline, and ask the patient that from which ear she can hear it better. Whether she can hear it equally in both ears or in any other ear. After that, I'll ask the patient, and since the patient is comatose, so I cannot do the vestibular testing as patient cannot stand. And but if she can stand, then I could ask patient to stand and march on his standing position, but by stretching the arms. I'll then go directly for the otoscope examination to see inside the ear for tympanic membrane, for any hemotympanum like that. I'll see if it is okay or not. After that, seeing the tympanic membrane, whether it is busted or it is intact, or what is the presence of blood in tympanic membrane or not. Then I'll also examine the cranial nerve 5, that is trigeminal nerve. I'll take the cotton wool and touch the patient's arm and ask if she can feel it there. Then I'll ask patient to close the eyes. When she'll close the eyes, I'll explain him that when her that if she can feel the same as the arm, she can say yes by whenever I'll touch. Then I'll start touching over her forehead and then again on the cheekbone and the jaw, over the angle of the jaw on both sides of her face, and see if there is any deficiency in the trigeminal nerve. I also ask the patient, I'll do the motor examination of trigeminal nerve by asking the patient to close the jaw against my hand's resistance and try to open the jaw against the resistance also, if she can do it or not. And then I'll ask the patient to clench her teeth, and I will try to feel for the masseter muscles and temporalis muscles whether it is tightened or not. And then I'll ask the patient to raise the eyebrows and then close the eyes against my hand's resistance. Then I'll also try to ask the patient to blow her cheeks, and I'll ask her to saw her teeth and also tense the neck area. After that, I'll also ask the patient to if she has any uh, decreased taste sensation or not. For that, if she can do, I'll put some salt or sour over his chest and do it if she can feel it. After that,
Which two cranial nerves can you examine together?
I'll examine the cranial nerve 7 and 8 together.
Okay.
First,
Yes, how?
because he has ear deafness, so I'll first examine the cranial 8, and then after that I'll examine the cranial 7, and then if she also has facial injury, so I'll try to examine the cranial 5 also.
Okay. Yes.
To complete the examination, I'll thank the patient. I'll wash my hand, and to complete my examination, I'll do the full examination of all cranial nerves.
Okay. So can you present your case now? What were your findings?
This 23-year-old girl, which 23-year-old girl, which got the road traffic accident, and she got the trauma of his head and bleeding from the nose and unable to hear from both ears. On examination, I found that she's got right-sided conductive hearing loss, as well as presence of hemotympanum on autoscopic examination.
What are the differentials that you will consider?
In this condition, I'll also think of the head trauma with basal skull fracture.
Yes.
Also, there are other therapeutic nasal packing in case of epistaxis or other nasal surgery, and there may be blood disorders, or there can be a middle ear infection.
Okay. How should this patient be managed?
First of all, we'll do the proper investigation, all the blood, full blood count, urea, electrolyte, and other coagulation profile. But after that, we'll go for imaging. I'll do the CT brain, also advise for audiometry. And after that, I'll consult the ENT consultant to do the further review of this patient regarding her ear injury.
Okay. Can you help me to read this? What is this that you're looking at?
Ma'am, this is the autoscopic view of the tympanic membrane from the, I think it is of the
Which side?
it is the right ear. It is the right side, ma'am.
Can you tell me what causes hemotympanum? Secondary, I've already said it, okay. Can you tell me how would you use otoscope? How procedure? Can you explain it in few sentences?
Yeah. I'll held the means otoscope like we held the pen. For example, if I have to examine the right ear, I have to hold it in the right hand. If I have to, and vice versa, then I'll rest my hand over the patient's cheek so that it will be stable. Then I advance the otoscope by seeing directly under it, directly, and then gradually first I'll look for any wax. Thereafter also any swelling, any erythema, or any foreign body inside, and then after then I will see the examine the tympanic membrane. In that I'll first see the color of the tympanic membrane, and then any bulging or erythema is present or not, any perforation present or not. Then I'll see the light reflex. Actually,
Yes.
ma'am,
How
what
would
I
it be?
said, I think it
Yes.
is a left ear,
Yes, it's left.
left ear.
It's
Light,
left. Yes.
yeah, light. Actually, this cone of light, if it is around the 5 o'clock in a clock, it should be on the left side. If it is on the 7 o'clock, it should
Yes.
be of right ear.
Yes.
Yeah.
Yes. They have told you. All right. Okay. Good. Right.
And then I'll slowly withdraw
How
the
would you withdraw?
otoscope.
Yes. Carefully.
I'll withdraw it carefully, slowly.
Very
And
good.
one thing I forgot to tell, ma'am, I'll stretch the pinna
Pull.
upward and
Yes.
backward to
Yes.
make
This is what I wanted
pull
to
it
hear.
upward and backward
Yes.
to make it straight. Yes.
Yes. Upward and backward. This to make it straight into an otoscope to fit
Yes.
in it.
With
This
with
is the
one,
keyword which
yeah,
I
with
wanted
one
to
hand.
hear. Yes. Very good. You remembered yourself. So good.
Yeah, yeah, yeah.
Okay. Yes. Feedback. Who wants to give feedback? It was good. But
Yes,
one
ma'am.
thing, it was not RTA, road traffic accident. It was horse riding. It's sport
Oh, sorry.
accident. Yeah. So like
Yeah,
this, you
yeah.
have to
Sports
be careful
accident.
when you are presenting. Sport accidents are
Sure, sure.
different from
Yeah.
RTAs, even when they are the yeah. Yes, Dr.
Right,
Vishek.
right, right, right. Yes.
Yes, Dr.
Yeah,
Vishek. You
ma'am. Can you
wanted.
please show the picture, ma'am? Yeah.
Yes, please. Yes.
Ma'am, it's right-sided tympanic membrane, ma'am. It's not left, ma'am.
How? I think
Where is the cone of light, Dr. Abhishek?
Yes,
If
cone of light
you,
is not visible because there is presence of
yes,
medullary effusion and there is
effusion.
presence of
Yes.
yes,
bulging. So you cannot see the cone of light in the 4 o'clock or 5 o'clock position. You can say the
okay,
handle of the malleus. Okay, it's starting from the 1 o'clock position, like upper right corner and going towards the lower left corner, and it is stopped somewhere in the middle at the level of umbo. So in case of left-sided tympanic membrane, you will see the opposite. So the handle of the malleus will start from 11 o'clock or 10 o'clock position
okay,
or
okay,
upper left
yes,
corner. Okay.
okay.
So this is actually
Mhm.
right-sided tympanic membrane.
Mm. I don't know, actually on the
I
in
am
the
myself not.
five,
I thought it
four
was
or
left.
five position, yeah, 4 or 5 position, there is some means pallor area. So I thought that maybe the cone of light, because it is not completely visible due to
No,
you are
it's
you said it
here
right.
you are seeing
Human,
it is the umbo actually, the middle position. Yes, like
yeah, no, 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 yeah, I know that middle is the umbo, yes.
yeah, yeah.
Mm.
So
Okay,
that's from me actually, and you did
yeah,
great, Dr. Suman. Yeah, you touched
Yeah.
every
handle
point.
of, no, please give me some feedback so that I can improve more.
No, no, no. You are like
Actually,
Uh,
for me actually I do this station accordingly, like I divided it like inspection, and then I can go for the palpation one, and also then the also in inspection I can do the otoscope, then I can do the cranial nerves at the last. So you can follow the chronology if you want, so you cannot miss any point in that case. And in case of inspection, you also look for the sign of basal skull fracture. There may be recognize battle sign or autorhinuria if there is anything present like that. So that would be,
yes,
I
yes.
think, for ear examination, that is important, I think.
Yeah, I started that, but then I just kept this otoscope to do it
Yeah,
last. Yeah.
yeah. You can do like autoscope is like seeing, so we can use it and in inspection point. That's my point actually.
Mm, okay.
It's great, doctor. Yeah.
Hello?
Yes. Isn't this
Thank you,
like
Dr.
Ye-
Yusuf.
yes,
Yeah,
Yes.
yes, please.
yes, case is a little bit confused because in the examination said otoscope. And if we follow the chronological examination, maybe we
Yeah.
didn't have a time to use otoscope. As Dr. Do, you can start with ear examination, complete otoscope, and start again from the first cranial nerve, second, third, as chronological.
Yes.
This one thing. Other
Not,
thing, I don't hear a doctor said I will start with ABC when you ask him about management.
Yeah, he didn't. He said he'll complete his
Yeah,
examination. He
the
did say
patient
that.
is a campus trauma and he is semi-confused. Management
Yeah.
start by ABC.
actually,
Yeah.
if I had to consider this case of trauma, I should start as a ATLS protocol. Actually,
Yeah, yeah,
yeah, he's right. I concentrated only on the ear.
Dr. Zaid, actually,
That is the
yes.
yeah.
thing. But
You
actually,
do the examination. You do the examination perfect. But when the doctor asks you what's the management, you will start. You should start with ATLS protocol.
yeah, actually, it depends on the question. If the examiner manage this year,
Yeah, yeah,
then I'll,
yeah.
yeah. But if simple management means I should start with ATLS protocol. Yes.
Exactly. Yes. Thank you.
And I think in this scenario, I should start with the 7 and 8 cranial nerve.
First.
And if
Yes.
time gives, then 5. And then only I'll go to any other. I don't think that much time I'll have in the examination.
With practice, you can.
Even examiner will ask you not to do that. Yes.
Yeah. And as many as
Yeah.
you can, then the remaining you can explain at the end that which ones you didn't get the time, so you could have done those if time allowed you.
Yes.
Good, thank you. Okay, starting timer, and here is the question. Right, if you have read and understood, let's begin. Can you please identify the structure? What are you looking at? Which organ is this? And which view?
This is the liver from the below and behind.
Below and behind. Okay. Can you please identify structure 25?
Whatever, this is the right triangular ligament.
Okay. Where is the other end of this ligament attached?
The left triangular ligament is the left lobe of the liver.
Okay. Can you identify structure 2, please?
This is the caudate loop.
Okay. Structure 13, please.
Then, uh, this is the inferior vena cava. The,
20, please.
this is porta hepatis, the portal vein.
Portal vein. Good. Okay. Structure 5, please.
5, this is the laser
Common
omentum
hepatic.
in the porta hepatis.
Common hepatic vessel, I think. Yeah, and then number 9, please.
The gallbladder.
Yes. 11, please.
This is the hepatic artery. 5, this is the hepatic duct. Sorry.
Yeah, 21.
1, 2, 1. This is the quadrate loop.
17, please.
This is the ligamentum teres.
And 15 over here.
This is the left triangular ligament.
Yes. Can you please tell me how many parts there are of the liver? How would you divide liver? Anatomically, surgically, however you
It's
want to.
divided by the anatomically. There is a falciparum ligament. It's divided into the right and the left loop. This
Yes.
anteriorly and posteriorly. This is the laser omentum.
Yes.
This is the fissure of the laser spinosum. Surgically, it is a line drawn from the inferior vena cava to the fossa of the gallbladder.
Okay. So can you tell me what is the blood supply of the liver?
Supplied by the hepatic arteries. It's a branch of the celiac trunk.
Okay. And the venous drainage? Blood supply
It's
includes both.
hepatic vein to the inferior vena cava.
All right. Okay. Can you tell me the relation of the structures present at porta hepatis?
For hepatic, there is right and left hepatic duct, and here is hepatic artery and the portal vein posteriorly.
Okay. Can you tell me, can you name few ligaments which support the liver?
Okay, there is the falciparum ligament attached to the diaphragm, and there is the upper and the lower coronary ligament.
From diaphragm, the second end is attached where, please?
The first part of the duodenum.
Okay. And the lesser omentum?
There is
Lesser omentum.
the lesser omentum. It is the stomach and the first part of the duodenum.
Okay.
There is the right and left coronary ligament, and the upper and left, right and left triangular ligament, and upper and lower coronary ligament.
Yes, they are attaching liver to the diaphragm. Can you define a lesser omentum? What is lesser omentum?
Lesser omentum, this is a fold of the great omentum, I think.
Yes. Okay. Can you tell me the surface marking of gallbladder?
It is in the 9 costal cartilage
And
between the lateral border of the rectus muscles and the
yes.
9 costal cartilage.
Okay. Can you please tell me if there is inflammation in the gallbladder, cholangitis, why the pain is referred to the shoulder?
It is in cholecystitis, there is irritation of the diaphragm, which is supplied by the phrenic nerve,
Yes.
which is also supplies the supraclavicular nerve, found in the same route, C3, C4.
Yes. Can you tell me what are the parts of the gallbladder?
There is the fundus, and there is the neck, and there is the body of the gallbladder.
Fundus, body, and neck. Okay. And can you tell me where the gallbladder duct opens? Normally.
Cystic duct, which is accompanies the common hepatic. There is a cystic duct accompanies the common hepatic duct to form the common bile duct, which is
Yes.
open in the second part of the duodenum.
Okay. Can you tell me the blood supply of the gallbladder?
It's supplied by the cystic artery, which is the branch of the right hepatic artery.
Okay. Can you explain it to me again? What are the parts of right lobe of the liver? These caudate lobe and quadrate lobe,
The
these
right,
are part of which? Right liver or the left liver?
it is anatomical part of the right liver, but functionally it is considered to be part of the left lobe of the liver.
Okay. What is the bare area of the liver? Why is it called bare area of the liver?
There is no attach of the ligament. The great momentum is not attached to this area, so it is direct contact with the visceral organ.
Where is it located? Can you identify?
Number 1.
Okay.
Number 1,
Okay, right. Yes. So, what is the nerve supply of the liver? How liver gets its nerve supply?
mm, I don't know what
Okay,
through the
if a
vagus nerves
person
and
gets stabbed in the epigastrium, what are the organs which are likely to be injured?
the stomach and the left lobe of the liver,
Okay, why?
because this is the most anterior in the upper part of the abdomen.
Yes. Where does the accessory cystic duct opens?
Just superior due to the second part of the in the second part of the duodenum.
Okay, superiorly, yes, above. All right. Can you tell me what is the most common hepatocarcinoma? Common type of hepatocarcinoma?
Vascular carcinoma, squamous cell carcinoma.
Six grams. Okay. What should be the management of liver carcinoma? Hepatocellular, hepatocellular carcinoma.
After history and examination, they
Yes.
should do staging by CT or MRI.
Yes.
Thus, in MDT,
Yes.
then patient might need to surgical treatment.
Does the chemoradiotherapy works for patient with liver carcinoma, or does it have to be resection or surgical management?
I think this chemotherapy does play a role in the management.
Depending upon the grades, how would you grade carcinoma of the liver?
I don't know.
Okay, what about the gallbladder? Gallbladder carcinoma is common in males or females?
It is in female.
Yes, it may be. I think so. Yeah. Thank you. Good. So, as we had
Thank
not
you.
much choice, just the liver and gallbladder we had to do. So, thank you. Starting the timer, and here is the question. Right, if you have read and understood, kindly begin your history taking.
Okay. Hello, good morning. I'm Dr. Abhishek, one of the surgical candidates here today. May I confirm your name and age, please?
My name is John. I'm 64.
Okay, John, it's nice to meet you here today. So today I have been asked to ask you a few questions regarding the problem you're having. Is that okay with you?
Yes.
Okay, so can you please tell me how can I help you today?
I have this pain in my tummy from last few days.
Okay. So I'm really sorry to hear that. So can you please tell me for exactly how many days you are having this pain?
It's going on and off from last couple of months, maybe 6 months. But it
Okay.
got worse in the last 2 days.
So yeah, or in the last 2 days. Okay. So did it start suddenly or gradually?
Started suddenly, but it's just getting worse now.
Okay, last 2 days is getting worse, right?
Yeah.
Okay, so can you please tell me, is it present all the time whenever you pass a stool or sometimes?
It's like a slight ache all the time, but it just gets worse in the last 2 days and just there all the time in the last 2 days.
Okay, so is there any period you're having some stool without any without any pain, something like that?
Not from the last 2 days, no. I'm
Okay,
I'm
so is there
I
anything?
I haven't passed any
Yeah, please.
stools in the last 2 days either.
Okay, so can you please tell me, is there anything that makes the pain stops, or like any medication you take whenever you take the medication, the pain get stopped, something like that?
I take paracetamol and ibuprofen, which does help for a couple of hours, but then it just comes back.
Okay, can you please point out like where is the
It's
pain
everywhere.
actually?
It's all over my tummy, doctor.
All over. So from the tummy, does it go anywhere else, or is all in the tummy only?
No, it's just in the tummy. At times, I do feel like it's going towards my back, but I don't think it's related.
Okay, good. It goes to your back. Okay, so can you please tell me, like on a scale, like 0 means no pain and 10 means the highest, worst possible pain, how do you mark it?
9 at the moment.
Oh, I'm really sorry to hear that. Do you need any painkiller at this moment so that we can continue later?
No, just carry on. I just want to know where it is.
Okay, so how is it affecting your day-to-day life? How badly? Can you please tell me?
I haven't passed any stools from last 2 days. It's just painful all the time. I can't do anything. I can't eat. I can't sit.
Okay, I'm really sorry to hear that. So other than this pain, is there any condition you are facing?
What do you mean?
Any problem? Like other than this this tummy pain, are you facing any other problems related to your health?
No, I'm good. I'm in a good health.
Okay, did you have any episode of passing blood through your stool?
Yes, in the last 6 months, I'm passing
Oh,
blood.
okay. So what is the color of the blood? Can you please tell me?
It's like a dark blood, not very dark, but dark,
Okay.
dark.
Okay, so is it present like through the whole stool, like, or at the beginning or at the last?
I pass blood even without passing stool.
Oh, okay. I'm really sorry to hear that. So can you please tell me, how's your appetite been now nowadays? Have you noticed any change there?
I don't want. I just feel like I've lost my appetite.
Okay. And what about weight? Have you lost any weight?
Yes, I think approximately 10 pounds in last just few weeks.
Okay. So what is the amount of blood do you pass? Like it's a huge amount of blood or something like a teaspoon or streaks, something like that?
When I started last 6 months ago, it was just like drops of blood. Now it's like a lot of
Okay.
blood. It's hard to
Okay.
say
So did you
exactly,
have
but it is a lot.
Okay, so you are having also constipation. So, is this constipation only for 2 days, or do you have any previous episode of long-term constipation also?
I do get constipation on and off at times, so it's not unusual, but it's just not getting settled down this time.
Okay, so have you noticed that during passing the blood, did you have any pain in your back passage?
Yes.
Oh, okay. I'm really sorry to hear that. Have you noticed any mucus or discharge with your stool or with the blood?
It's just so much blood. It's hard to say, but I don't think I have.
Okay, I'm telling you certain like symptoms. Can you please tell me whenever you had any kind of these symptoms, like any fever during the recent period?
Nope.
Okay, any painful red eye?
Red eye. No.
Yeah.
No. No.
Okay, so any joint pain?
Well, I'm 64. I'm an old man. I get pains in my joints all the time.
Any specific joint pain,
No,
like
no,
any
no,
specific more
no.
pain? Okay, so any skin problem?
No, just have a dry skin.
Okay. Okay. Did you notice any type of swelling or any itching at your back passes?
No.
Okay. So can you please tell me, like, is it for the first time, or did you have this type of problem in the past also, other than this 6 months?
I get constipation, but other than that, no. I've never had any issues with the blood before. I never had this kind
Yeah.
of pain before as well.
Okay. So did you have any surgery in the past?
No.
Okay. So are you taking any regular medication or seeing your GP for any kind of disease regularly?
I take amlodipine for my blood
Okay.
pressure, and
Okay.
I don't really see my GP. My BP is well controlled now.
Okay, that's really good. Did you have any of your family members have similar type of problem? Can you please remember that for me?
I can't remember. I don't know.
Oh, okay. So are you allergic to any kind of medication
No,
or
no,
any
not that I'm
food?
aware of. No.
Okay. Can I ask you a few more personal
Yeah, yeah.
questions? Yeah. Do you
Yes.
smoke? Okay. How often? How many sticks per day? Can you please
I
tell me?
started when I was 20, doctor. So it's been 35, 40 years
Okay.
now.
So how many sticks? Yeah. How many sticks
Maybe
per day?
20.
Oh, okay. So do you take alcohol?
Yes. Just on and off.
How often? Okay. So, like, do you have to climb the stairs at your home?
Yes, I do.
Any problem in your stair
No,
climbing?
I'm otherwise pretty fit and well.
Okay. So, who is at home with
My
you?
wife.
Oh, okay. So, before going any further, can I please ask you, like, what is the idea, about the problem you are having? Can you please tell me?
I just one of my friends has cancer in his bowel, so I'm just scared that it
Okay.
might be that. Do you think it is?
Okay. So, what is your most concern regarding this, your
That's my
situation?
concern.
Okay. So, what are you hoping us to do for you as an urgent basis or emergency basis? Can you please
I'm
tell me?
expecting you to tell me what's going on with me.
Okay, we'll definitely look into that as early as possible. Can you please tell me, did you have any kind of hand pain or hand weakness, leg weakness, something like that? Did you have ever experienced that?
No,
Okay, so any kind of problem in passing water?
no,
Okay, thank you so much. That completes my questioning. So do you have anything to add actually that I have missed?
no. Thank you.
Okay, thank you so much. Thank you so much for your cooperation.
No worries. You have done a good job. Well done.
Can
My
you
pleasure.
present your history now?
Yeah, today I have taken history a 64 years old male who comes where he was reasonably well 6 months back. Then he developed episodes of constipation, intermittent constipation, and for the last 2 days he's having like a severe constipation, and without passing stool, he's just passing fresh blood, and there was no aggravating and relieving factor. And about his he has also complained of abdominal pain, and there is no aggravating factor, but there was some relieving factor by taking paracetamol. And he has also history of weight loss and loss of appetite, and there is no other significant history of inflammatory bowel disease or diverticular disease or other long-standing constipation or any other perianal swelling or in itching. So he
So,
has
what is
also
your differential diagnosis?
so according to the history, my differential diagnosis would be, it may be a case of colorectal carcinoma, or it may be a case of inflammatory bowel disease, it may be a case of diverticular disease, or it may be a case of bleeding diathesis, or it may be a case of anorectal cause like hemorrhoids or anal fissure.
How do you plan to manage this patient?
Okay, I have taken the history. I'll do a thorough clinical examination that would involve the abdominal examination, and if there is no contraindication, I also do a digital rectal examination. After doing that, I'd like to prefer some test for this patient. Like I'd like to do a full blood count, ESR, CRP level, serum electrolytes, creatinine level, liver function test, coagulation profile, and also patient is having bleeding. I will also group and cross match some blood. And after doing that, I can also do for stool microscopy and culture is a blood embryonic antigen level. And after that, I would like to go for the definitive investigation like colonoscopy when the bleeding settles. And in an OPD basis, we can do a rigid sigmoidoscopy. And after that, we can also go for a CT scan of the abdomen with contrast and abdomen and pelvis with contrast.
Okay,
Yeah.
good. All right. Yes, thank you.
Okay, ma'am. What was the time actually, ma'am?
You took more time actually. If
Yeah,
we
I know.
just consider the time, you took more like 2 minutes and 15 seconds extra, just finishing off
Yeah,
history taking, and then the remaining time I have asked you for questions. So
yeah.
yes,
Actually,
anyone
there are a
else
lot of
want to?
questions, ma'am.
Yes,
There's
definitely, but
many.
yes, you have to ask the
Yeah.
most important one. One question you repeated about the pain, joint pains, like this. I thought you have repeated yourself with.
Okay.
Yeah,
Yeah,
this
I
time
guess.
could have been saved. Like if you asked
Yes,
once, patient
yes.
says no, no pain, or
No
yes, yeah.
radiation. Yeah.
So that this could have been saved. More, yes, Dr. Vajia, would you want to give feedback?
Just a couple of questions. You almost covered everything, and your questions
Yes,
were very direct, so that was good. You asked me about uh, any other problems. I didn't really get your question. What you were asking, if it was
Yeah, actually,
asking
you
about
didn't
medical
tell anything
problem.
about the passing blood. So I asked you two times about any other problems related other than
Yes,
this pain. So then
I
I
I
just
wasn't trying
guided
to
you
be
towards the
difficult, but you were
bleeding.
not very clear, so that's why I was like, no.
Yeah,
That was
okay,
one
okay,
thing.
no problem.
And the other thing
Yeah.
was with the colorectal cancer, if I am taking this history, I'll be more worried about someone having obstruction. So I would add on questions like if you have any nausea, vomiting, and the other
Yeah,
question
yeah.
if you have
That
noticed
should be
any
answered, I guess.
bloating, any distension of your tummy recently. That's what
yes,
the
but
thing.
he did ask you about the nature of like constipation and that. So he did try to rule out if it's change in the bowel habit is one of the thing, because weight loss and then change in the bowel habit and peer bleeding. These are the main concerning elements of the history taking for colorectal carcinoma.
And also my family history, if there is any
Yes,
positive
he
family
did.
history. Yes.
Yeah, he did ask you that. But then, okay, family history is not that much important. Nowadays, I've seen people can have individual carcinoma, doesn't have to have like history. But these three things he
And the
tried
other
to rule
thing,
out.
if again, like I said, if I'm taking history, I would ask
Yes,
someone with the bleeding history would be if they have developed any anemic symptoms, if they're feeling dizziness and all those things. You don't have to ask.
we
Yeah,
don't
of
That's
have
course, you
that
can
much
ask a
time.
lot of questions, Dr. Vajiha,
Yes,
but you know the time I asked
time
you
is
most of the
constrained.
question, but the time is still 2.5 minutes more.
Yes, it two
So
no, not two and a
yeah,
half, 2 hour, 2 2 minutes and 15 seconds. Yes,
15 second. Okay, yeah,
yes,
ma'am, 2 minutes and
yes.
15 seconds.
So to be precise, I was watching the clock because I have to make you or bring you within the given time. Yes, Dr. Tashaba, you want to add anything? Yes, please.
Ma'am, I need to ask that if you're considering
Voice has gone. I'm sorry if I have to consider what?
ma'am, if I am considering it to be the obstruction secondary to a carcinoma, so
Yes.
shouldn't I be evaluating the constipation more by asking whether it was relative or absolute, whether the patient is just not able to pass the blood test or unable to pass the stool along with that?
You know when this carcinoma obstruction is not always complete, not always, but can happen. Yeah, but many questions could have been asked, like, but then again,
Ma'am,
time.
so we should be asking about tenesmus, Purias diarrhea, and all these things as well.
I think I asked about tenesmus,
Yeah,
Okay,
Dr.
yeah,
Tashaba.
okay.
yeah, that he did. He even asked free or mixed, so he even concluded that. According to the history, patient said
About
it
and
was
ma'am,
dark
the
colored.
questions are buzzing
Okay,
around my head actually, but I just skipped also. Yeah, ma'am.
which one?
No, ma'am, I'm just saying that many questions are buzzing around my head, but
Yeah, yeah, yeah.
time was also
Oh,
important.
Dr.
So I
Suman
just
Kumar, I'm sorry, you're doing 100 things. Okay, yes, many questions can be asked, but then you have to be straightforward. And then time is 6 minutes only. It's not that easy to cover everything.
Okay,
But
ma'am.
three main important things like weight loss, change in bowel habits, and bleeding PR. Like you have to ask all the questions related to this one. Yes, important also. Pain, yes, pain also. Yes, very good. Okay, thank you so much. Here.
No, no, it's okay.
Yes, timer is on, and here is the question. Right. If you have read and understood, kindly begin your station.
At the room, I'll enter the room, wash
Yes.
my hands, and I'll
Yes.
greet you. Hello, I'm one of the surgical candidate. May I please confirm your name and age?
Yeah, doctor, I'm Thomas, 32-year-old.
Okay, Thomas. So
So I can't hear your voice, Dr. Nadine. Voice is gone. Yes.
Yeah, I'm just waiting my,
yes,
hello.
yes.
I am just waiting for my operation to be done on my knee joint today. So I'm just waiting my turn now.
Okay,
Is it my
Thomas.
turn came now?
Thomas, I can really understand the pain you have been going through, all the time. But I'm really sorry to tell you that today we would not be
What?
able to go with this surgery. Do
What?
you
What
understand
are
it?
you telling?
Can you?
No, today is my operation. What do you mean by that? Not going to tell?
Yeah,
What do you mean?
yeah, Thomas. Yes, I'll explain it to you, Thomas. Can you please sit down, if you don't mind? Just sit down for a while.
No, it's okay. I'm sitting. It's okay. Okay, I'll sit
Okay.
down here. Okay.
Oh,
You
thank you,
just tell me
Thomas.
about this operation. Today is my operation. I have been informed about that.
Yes, Thomas, I do understand your concern. You had been scheduled for today. You had to undergo this surgery. You were cancelled twice even before. Despite all these things, I'm really sad for you even. But my consultant had to go to some more important surgery. So we could not cope with this. Like we could not continue
No,
with the
no.
schedule. I'm really sorry.
What is that? Actually, you think that my operation is not important? It is the other operation is important. I want to talk to him right now. Can you call him now?
Thomas, I'll definitely make an appointment for you to meet him. Yes, I'll help you in that way. But can I please explain few of the things that why we had to take this difficult decision to cancel your operation? Definitely, your operation is not less important, but we have to make some difficult decisions. Like when there is life-threatening condition or life-threatening emergency, then we have to go for that operation. Do you understand that?
Can't I talk to him right now?
Well, at the moment he is busy in the emergency surgery. So I'm really sorry. It would not be possible for me to make you talk him at this time.
So
Maybe
I'm
later on.
really, I am very angry. Actually, should I consult another consultant to do it now? I need another consultant so that he will do operation now.
Yeah, Thomas, please accept my apologies again. And yes, I can help you in another, taking an appointment for another consultant. But do you know, your case has to be started again, and it will start from zero. It will take a lot of your time. So a lot of new process will start again, right from zero. So I
You
fear that it will
know,
not.
doctor, I have already been cancelled twice, and again today you are postponing my surgery. So really, it is not good. What should I do now? What do you want me to do now? What should I do?
Yeah, Thomas, I do understand. It was
Doctor, can you
twice.
do this operation for me? Can you do this operation for me?
Thomas, I wish I could do it, but I have my limitations. I cannot do it independently. My consultant has to do it. So I'm really sorry
Oh
to
my
let you
God.
know that it will not be possible for me.
Oh,
Mhm.
oh, really?
Okay, Thomas.
So give me right now. Give me the another appointment. I don't want to get in the trouble again. You give me another appointment
Thomas,
right now.
I'm really thankful for you to be so much understanding despite your pain. But yes, I'll definitely keep your number and medical record number, and will try to discuss with my consultant and the team to keep you on priority, and we will call you next time. Okay,
So
we will not.
you are saying that you will not postpone my surgery again, right? Right? You are
Still,
telling that?
still, Thomas, I cannot make any guarantees at this time because these
Oh my God.
unexpected emergencies they can land in any time. with due apologies, but still I'll make you on highest priority
So,
next time.
so you see that I am in so much pain. I cannot walk properly, and how you expect me? How can I work? My work is
Yes,
also
Thomas.
hampering. How can I work right now?
Yes, Thomas, I can. Yes, Thomas, I can help you in a few ways. Like I can write to your employer to give you more leaves. Is that right, Thomas? And I can give you a few more painkillers, and also send you to a physiotherapist to give you some tips or advice regarding exercise to strengthen your muscles of the knee. And also you can continue with, bicycling or exercise like swimming.
Okay, doctor. Right.
Mhm.
Last time I took the medicine for pain, it is causing too much heartburn to me. I'm feeling very irritation. It's causing
Oh,
heartburn and
Thomas, I'm
bloating
really
to
sorry
me.
for that.
Yeah.
Oh, Thomas, I am really sorry for
Can
that.
you
So
give me another medication, please, doctor?
yes, I can switch over to some other medication, and I can also add omeprazole to, have a protective effect for your stomach. Is that right, Thomas?
Okay, so I hope you people will do my surgery next time. I'm really, what should I do? Oh, God.
Yeah, Thomas, I really feel for you. I'm really sorry again, but you understand how the things work in hospital in this condition. All the things are so much unexpected at times that it's not in your hand. But still, we are here to help you, and we'll contact you again to put your name on earliest possible list. Is that right, Thomas? So if you have any
Oh,
more questions, you can ask me now or even later on, and we can also make an appointment with the consultant. And can you please summarize what we have discussed? Like if
Patient
you
would
have any
still want
few
to
more
complain,
questions.
so you have to give the forms.
So
yeah, actually, suppose I want to complain about
you want
this.
to
So,
complain? Okay,
yeah,
Thomas,
do you have any? Yeah.
yes, Thomas, we have a system pass patient, they can complain in this, in the hospital. I can show you, I can guide you, and you can, show your genuine concerns and write them there. Yes.
Okay, I'll see what to do about that, but please give me that form and okay, I'll see.
Yes, I'll give you.
I'll
Thank you for being, thank
okay.
you for being understanding, Thomas. Thank you. Nice to meet you.
At the end,
Okay.
you'll say, I will leave my number with the nurse. And if you have any more question or query, you can contact me. This should be the
Yes.
closing
Okay.
sentence,
Yes.
right?
And you should summarize the whole thing to me
Yes.
again if you have
Yes,
time.
Thomas. So what we have discussed, Thomas, today, can you summarize it for me, or should I summarize it again for you?
Uh, Actually, you should summarize. I
Okay.
am very angry.
So
I'm
we
not
have
in a mood to
Yes.
discussed,
summarize it.
right, Thomas. Okay. So I have to discuss with my consultant about your case. We have to put it on priority, and we will call you back. And I'll also refer you to physiotherapist, and I can also write to your employer. And
And
I
you'll
have
change,
suggested you
add the
some
medication.
painkillers, and I have changed the medications, and we'll call you back. And you can also call me. I'm leaving
Yeah.
my number with the staff. Is that right, Thomas?
Yes.
Okay. Okay, doctor.
Thank you, Tom.
Thank you.
Be my patient like this,
Okay.
Thomas. Thank you.
Thank you, Dr. Suman. You
Okay.
were really like making it sound like
No,
real
man, not
patient,
that
real
much.
You
angry
were more
patient.
empathetic.
So it was good practice for Dr. Nadeem to have you today.
Yes, he
Yeah.
was more empathetic than me. Okay.
Good. Here is the question.
I think I've done this one before.
Have you?
Yeah. No, I think I've simulated for someone.
Yeah.
Yeah.
Please.
There's something with this one.
Bringing out from lower limb choice is little, even we have done in recent days. since now we're following the schedule, so many of the stations will be repeated, maybe in near days. So if you have read and understood, kindly begin your history taking.
Hello.
Yeah.
Hi, my name is Dr. Zara. I'm one of the orthopedic doctors. Can I confirm your name and date of birth, please?
Yeah, sure. I'm David, 28 years old.
Oh, hi, David. Nice to meet you.
Yeah, for
What
me
brought you
too.
to what brought you to the hospital today?
Okay, doctor, I'm having some pain in my left knee for a few months.
For a few months, and it started all
Yeah.
of a sudden.
Yeah, it started suddenly 3 months back, actually. Yeah.
Okay. Is there any specific point where you feel tenderness, where you feel
Yeah,
this pain?
right at my knee joint, left knee joint.
Right at your left knee joint, but is it like all over the place, or there is any specific point where you feel it?
No, specifically on the left knee joint, actually. So it doesn't go somewhere else.
Okay. Um, what kind of pain is it? Is it like a sharp throbbing pain, or is like a slight ache, dull pain
It's a dull pain, but I experience it more when I walk, actually.
when you walk? Okay.
Yeah.
And is it there all the time, or it comes and goes?
Yeah, actually, in the morning, there is no pain. And at the end of the day, I feel much pain.
Okay. And any particular position you feel the pain gets better?
No, whenever I take some medication, the pain gets better. And I am taking that for last 3 months.
And what do you take for your pain relief?
Normal painkillers like paracetamol.
Okay. And anything which makes it worse, like you said, when you walk.
Yeah, walking at the end of the day after doing all the working and activities.
Okay. Any pain in your back?
No.
No pain. Good. And if I ask you to rank this pain from 1 to 10, 10 being the highest, how do you
Yeah.
think it is?
Like at the end of the day, it's like 6 or 7. At the beginning, I can say it's 2 to 3.
Okay. And have you had any troubles with this knee before?
Yes, I had some injury of ligaments and I had some operation. I can't remember actually. That's 10 years back.
10 years back. Okay. And was it
Yeah.
this pain, do you think, is it the same pain or is it different this time?
It's different, doctor.
Have you noticed any swelling at your knee joint?
No, doctor.
No redness around it?
No,
Any before 3 months, do you remember if you had any injury or any trauma to the knee?
no.
So it just started all of a sudden
Yeah,
and
it started all of a sudden and increasing. Yeah, doctor.
right. And sorry, just remind me again. You said no swelling, right?
No,
Yeah.
doctor.
Do you feel stiffness in your knee joint?
No, doctor.
Any locking, or do you feel like the knee has given way when you're walking?
No,
No. Okay. Any other joints in the body which give you similar trouble?
no,
Okay. And any temperatures, rigors, or chills recently?
no, doctor.
Good. Um, any other medical problems?
No, doctor, actually.
Good. And are you on, apart from paracetamol, any other medication you are on?
No, I didn't try anything other than paracetamol.
And do you have any allergies?
No, doctor, that can I remember.
Good. And what do you do for your living?
I am a professional footballer, doctor.
Oh, good. So you have a pretty
Thank you.
active lifestyle then.
Yeah.
Do you smoke?
Occasionally, not much, doctor, like once or twice in a month.
Okay. And do you drink alcohol much?
Same goes with alcohol, doctor.
Okay. Anyone in the family with the similar problems with the joints?
No, doctor.
Right. And do you feel any pins and needles in your leg? Any numbness in your leg?
No, doctor.
Okay. Any swelling at the back of your knee joint?
No, doctor.
And any change in the color of your leg overall?
No, doctor.
Good. Is there anything else you want to add on which I didn't ask?
Yeah, doctor, I have noticed some change of shape of my left knee joint, doctor.
Shape change.
Yeah, yeah.
And when did you notice that?
Yeah, it's like for last 3 months, doctor, and I think it's getting worse.
Okay, just tell me more about it. When you say change in the shape, do you mean like it's not in the right place, or is it more medial? Is it more lateral, more towards your other knee, or more towards outward?
Yeah, I think it's more towards outward, doctor. Though I
Outward.
can't understand what is medial lateral, I can see it's more towards outward. Yeah.
Okay. And you didn't have it after your surgery.
No, doctor, I recently noticed that.
Okay. Um, and do you think this change in the shape is getting better, worse, or still the same?
It's getting worse, doctor, actually, with pain. Yeah, I have told you.
Right. And is there anything else you want to add on?
No, doctor, that completes my query, actually. That completes my problems.
Okay. What are you expecting is going to happen in this clinic appointment today?
Yeah, actually, right now I'm really concerned, and I'm taking into mind that maybe I had some surgery in the past, and that is causing this problem. And I'm really concerned that I'll be able to play football again or not. That is my concern. Yeah, doctor, and do something as early as possible for me. Find out what I am having actually.
Yeah, they are very genuine concerns. Thank you so much for your time. Have a good day.
Yeah,
I'll get back to you as soon
my
as I can.
pleasure.
Okay,
Thank you
thank you.
so much. Yeah.
Thank you.
Can you please summarize your
So I
history
have been
treatment?
asked to take a history from a 28 years old, otherwise fit and well footballer who is having sudden onset of pain in his left knee started 3 months ago on the background of a surgery which was done 10 years ago for some ligament damage. He did not report any swelling or any erythema or any signs of septic arthritis. He did notice some change in the shape of his left knee joint, which started at the same time and is getting worse with time. He struggles to walk. He reports no neurological deficit in his leg and no vascular deformity as well.
So what are
Um,
your differential diagnosis?
my top differential in his case would be a valgus deformity of unknown cause, which I don't know. It's unlikely, but it can be arthritis, or it can be as a consequence of his surgery.
Okay, so what are the investigations that you are planning to ask for him?
From investigations point of view, I will start with the baseline investigations. Uh, baseline investigations like baseline investigations like full blood count, UNEs, clotting profile, and group and safe, and urate and calcium profile as well, and bone profile as well. He needs X-rays with the joint above and below, followed by an MRI scan.
So what are the management or treatment that you can offer this patient?
That it will depend upon the underlying cause. Most likely, if it's ligament damage, he will need he might need an arthroscopy to look at the further cause of his pain. But if we are treating him for osteoarthritis, it can be managed with the non-medical, with the medical management and the surgical management. Conservative management will include rest, elevation, ice, and NSAIDs, and we can
What are the
offer steroid
surgical
injections.
options that you can offer this patient?
We can do arthroscopy and knee replacements,
Okay, total or partial.
total partial, yeah.
Okay, what about realignment osteotomy?
Yeah, I don't
Okay,
know what.
all right. Do you think this patient will be able to play football in the time of 10 months?
In 10 months' time, he will need good physio, but probably a year he will be.
In a year or yeah, longer than that.
Yeah.
Okay, good. Okay, intraarticular steroids. Also, they have said
Yeah, I can get your
arthrocentesis as well. One of the management. All right. Okay, good. Right. Good. Okay.
Yeah,
Very great.
it was really
It
great.
was
Yeah,
good.
ma'am.
Just
Dr.
few
Vajia asked all the
seconds.
questions.
Yes, and he kept the time in her like control as well.
And I also
Okay.
wanted to maintain that the answer is clear cut, something like
Yes.
that.
Yes.
So yeah. So in this case,
Abhishek.
Dr. Wajia, actually the most provisional diagnosis is post-traumatic osteoarthritis.
Yes.
You can,
post-traumatic
yeah,
osteoarthritis. Okay.
Yeah, like there may be change of
he
shape,
told
like
you
some
more
cardinal
than
feature.
10
Yeah,
years ago he had the
yeah,
surgery.
No,
in the
but you
same
said
day.
that you don't have stiffness, early morning stiffness.
Early morning
That's
stiffness are
like
with
for
yes,
rheumatoid
yes,
arthritis,
that's a
yes,
rheumatoid.
not
Oh
for
yes,
osteoarthritis.
osteo is
Yeah,
good. Yeah,
yes.
okay. Yeah, that's what caught
yes.
me off
Okay.
guard actually. So yeah.
And he
Right.
was
So
also telling you how in the beginning it was less, and at the by the end of the days overuse,
yeah,
Yeah,
joint
yeah,
that's
yeah.
the
overuse.
cardinal
So
features of
yes,
osteoarthritis.
Osteoarthritis. Yeah, I think I
yes,
mixed up osteo with the rheumatoid arthritis. I was thinking about rheumatoid, but yeah, that's
yeah.
fine.
That's why I thought he's clear cut, like telling you, indicating that what that is, and
Yeah.
so all right, good, very good.